Okay, thank you so much for joining us today. I'd like to welcome you to the STS 2024 webinar series. Today's webinar is titled Emerging Role of Circulating Tumor DNA in the Management of Thoracic Malignancies, and it is sponsored by AstraZeneca. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. At this time, I'm pleased to introduce our moderators for this evening, Drs. Schumacher and Sapisi. Dr. Schumacher, let me turn it over to you.
Thank you, and thank you for everyone who is joining this webinar tonight. We're really excited to have two excellent speakers today really give us a comprehensive overview on how we're utilizing circulating tumor DNA in the evaluation for lung cancer and esophageal cancer. So we have two experts, Dr. Vincent Lamb from Johns Hopkins Sidney Kimmel Comprehensive Cancer Center and Dr. Matthew Strickland from Massachusetts General Hospital. I'm really thankful that we have the support of the STS and AstraZeneca to be able to do this series. And I also wanted to introduce my co-moderator, Dr. Boris Sepsi from Health One Physicians Group in Aurora, Colorado. Dr. Sepsi, do you want to introduce our first speaker?
That's right. Thank you very much, Dr. Schumacher. So I would really like to thank everyone who is over here. We do have an excellent expert, friend of mine. We worked together early on in our careers on circulating tumor-free DNA, and I'm really excited to introduce Vince Lamb. He's an assistant professor, medical oncology at Johns Hopkins, and I look forward to learning more about the application and where the field of circulating tumor-free DNA is going. So Vince, thank you for being here, and take it from here.
Dr. Lamb, you're on mute.
Here we go. Thank you so much, Boris and Dr. Schumacher. It really is a pleasure to be here tonight to join in the discussion about the role of circulating tumor DNA in thoracic cancers. So to start us off, I'll be focusing on lung cancer. We'll briefly review the background on circulating tumor DNA and how it's currently used in the clinic, which is primarily in the metastatic setting. We'll then discuss the specific challenges and emerging data for its use in early stage disease, and finally wrap up with a preview of what's next in the clinical development of circulating tumor DNA. As many of you are likely already aware, blood-based ctDNA, which is extracted and sequenced from plasma, is really an ideal analyte for characterizing and tracking cancer. It is a non-invasive test, which is helpful because it allows for frequent and longitudinal sampling if needed. It has a relatively short half-life, about 2.5 hours only, so it really gives an accurate snapshot of the current tumor burden, and perhaps most importantly, specificity of ctDNA is generally near 100%, so a very, very low false positive rate. So with those ideal characteristics, ctDNA has potential for use across the entire cancer journey, all the way from early detection and screening. You see here on the left in the diagram here, from early detection and screening to molecular evolution, characterization upon treatment resistance to the far right. For this talk, we'll focus on the two applications for which we currently have the most robust clinical data, and that is the use of ctDNA to identify actionable genomic alterations and to risk stratify and monitor lung cancer disease. So in lung cancer, NCCN guidelines currently recommend testing for actionable alterations in 9 specific genes shown here. So this is indeed standard of care for metastatic non-small cell lung cancer, and ctDNA is routinely used in the clinic to identify these actionable alterations for our metastatic patients. Of course, EGFR and ALK have particular relevance in determining the appropriateness of neoadjuvant or perioperative chemo IO in our early stage patients. But it's important to note that the commonly used ctDNA tests are not nearly sensitive enough to genotype these early stage patients for this purpose. Because it is indeed truly akin to looking for a needle in a haystack, except even orders of magnitude more challenging. So based on the TRACERx study of resected non-small cell lung cancer, we see here that the percentage of circulating tumor DNA amongst all of the circulating free DNA in plasma, commonly termed MAF or VAF, this percentage goes down to minuscule amounts as the tumor size decreases. So for example, shown here, if you have a 1.2 centimeter T1B lung cancer, the MAF is estimated to be about 0.002 to 0.03%. So this is clearly outside of the limit of detection of the routinely used ctDNA tests that we have in clinic right now. And the good news, though, is that we have multiple ultrasensitive ctDNA tests currently in development that can detect early stage lung cancer or molecular residual disease after treatment, so-called MRD. So this is data from one such test that happens to be Personalis. This is a whole genome sequencing tumor-informed assay presented at ESMO last year and updated at ESMO this year, in fact, really representing what I think is amongst the best in class right now. So using the same benchmark TRACERx cohort, they showed impressive sensitivity with this new ctDNA assay, detecting 81% of lung adenocarcinomas in the cohort and 100% of the non-adenocarcinomas. Remarkably, you see highlighted in the box in the red here on the left, 52% of stage 1 adenocarcinomas. Again, adenocarcinomas are known to shed less than non-adenocarcinomas. So 52% of these early stage adenocarcinomas were detected with this newer whole genome sequenced tumor-informed assay. And this is a big jump from the prior generation MRD assays like Signatera is one that you might be familiar with. So importantly, to achieve this ultrasensitive performance, these assays are tumor-informed, meaning that tissue is required for a custom ctDNA library or a liquid biopsy to be prepared for that specific patient. And so these tumor-informed ultrasensitive ctDNA assays can only tell us for now whether or not there's cancer that's detected. So sort of a yes or no question, yes or no answer. And importantly, it doesn't tell us what the genotype is. So we cannot use these quite yet to, for instance, determine whether a patient, a stage 1 patient has EGFR or ALK. So armed with these more sensitive ctDNA tests, we have recently started seeing more compelling data from the large randomized phase 3 trials supporting the potential clinical utility of circulating tumor DNA in early stage non-small cell lung cancer. So this is correlative analysis from CheckMate 77T, which, as you may know, is showed improved pathologic complete response and event-free survival with perioperative chemotherapy plus nivolumab. So you see here on the left that more patients on this chemo IO arm that cleared their ctDNA prior to surgery, those patients, there were more of them with the chemo IO arm than on the chemo IO arm than in the placebo arm. And those patients that cleared the ctDNA were much more likely to have a pathologic complete response. In fact, none of the patients that had that still had detectable ctDNA after neoadjuvant chemo IO had a path-CR. So we see similar predictive utility of ctDNA clearance for path response in another large randomized phase 3 study. This is the AEGEAN trial, which led to the recent FDA approval for perioperative chemotherapy plus durvalumab. So in this study, even as early as after the first cycle, if you've cleared your ctDNA, you had a 49% probability of a path CR in the chemo plus durva arm. Conversely, if you didn't clear after the first cycle, you had an 89% probability of not having a path CR. So therefore, ctDNA really can provide an early predictor of pathologic response. Notably, all the patients with path CR and had detectable ctDNA at baseline, all of those patients with path CR did clear their ctDNA by cycle 4, day 1. So you might counter and say that, well, path response is nice, but what I really need to see is the utility of ctDNA for predicting survival outcomes. And again, in AEGEAN, we do see that patients that have cleared their ctDNA prior to surgery, as represented by the continuous red and blue lines in this Kaplan-Meier plot, those patients have improved event-free survival compared to those that did not clear their ctDNA, with an impressive hazard ratio for event-free survival of 0.26 in the chemo plus durva arm. And patients that don't have detectable ctDNA after surgery also have a much better prognosis, with a DFS hazard ratio of 0.05 compared to patients that still have detectable ctDNA at that time point. So putting it another way, these ctDNA tests, while not perfect, are quite good at detecting minimal residual disease that eventually leads to recurrence. And finally, this prognostic utility of ctDNA also extends to overall survival. In CheckMate 816, which is the randomized phase 3 that led to FDA approval of neoadjuvant chemo plus nivolumab, we do have mature OS data, indeed showing on the right that patients who cleared their circulating tumor DNA prior to cycle 3 of neoadjuvant therapy had significantly improved overall survival with a hazard ratio of 0.31 in the chemo plus nivo arm compared to patients who did not clear their ctDNA. So it's worth noting that these data that I've shown from the various randomized phase 3 studies utilize the early generation MRD ctDNA assay. So the prognostic utility of this ctDNA is expected to be even more impressive with the newer generation MRD assays, such as the Personalis assay that I mentioned earlier and others. So to sort of solidify that point, you can observe the room for improvement here in this Kaplan-Meier curve, where even the patients at the top of the curve, again in the solid lines, that did clear their ctDNA, you see that there's still a non-negligible rate of disease progression, really indicating that there's a certain percentage of false negatives that can be improved with better assays. So all of this is promising, but the key question that remains to be demonstrated is whether this early prognostic information can actually inform management and improve outcomes for our early stage patients. This, of course, requires a prospective clinical study, and there are several of these trials ongoing around the world. The issue, though, is that they are primarily adjuvant studies as they were designed prior to the current neoadjuvant perioperative chemo IO era. And so their results may be less relevant. So what we need to do is develop new studies in this contemporary neoadjuvant periop era to prove the clinical utility of ctDNA for our early stage patients. So putting together much of the data that we've reviewed tonight, conceptually, I thought it would be helpful to show 4 example clinical scenarios where ctDNA kinetics can inform treatment changes. So on the top left, you see that the initial ctDNA levels do clear for that patient during neoadjuvant therapy, as indicated by the shaded region. And so that patient may actually be a great candidate for a de-escalation approach where they may benefit from having less therapy in the adjuvant setting. On the top right, we see that that patient did clear their ctDNA during the neoadjuvant phase, but we see a recrudescence of the ctDNA levels in the adjuvant phase of their cancer journey. So that is an example of a patient that would benefit, for example, potentially from treatment intensification, such as the addition of chemotherapy or some other novel agent to adjuvant immunotherapy. Similarly, on the bottom left, we see another patient that with their ctDNA kinetics really suggesting a recurrence or a high risk of recurrence after initial clearance during the neoadjuvant phase. While the ctDNA levels for that patient are not as high as the previous patient, that really, again, presents a potential opportunity to intensify their adjuvant treatment to hopefully salvage a cure, for example. And then finally, on the bottom right, that's an example of a patient that really did not clear or have any sort of decrement in their ctDNA levels during the neoadjuvant phase, really suggesting potential primary refractoriness to the neoadjuvant therapy and really heralding very poor outcomes and again, presenting an opportunity for a potential treatment intensification during the neoadjuvant phase, or even potentially determining that patient is no longer resectable as due to the very high likelihood of micrometastatic distant disease. So while we don't have data yet from these type of ctDNA-directed MRD studies in early-stage non-small cell lung cancer, we do have tremendous optimism that these studies are indeed feasible and will indeed prove the clinical utility of ctDNA, for lung cancer. Our friends in colorectal cancer have led the way here, fortunately, with multiple ctDNA-directed prospective studies in, for example, stage 2 colorectal cancer, where the clinical benefit of adjuvant chemotherapy can be a bit of a gray area. So, very briefly, this is the dynamic study that evaluated a de-escalation strategy, and so published in the New England Journal in 2022. This is a non-inferiority study in which stage 2 colon cancer patients were enrolled and were randomized to either standard management, dictating adjuvant chemotherapy based on conventional clinical and pathologic criteria, or a ctDNA-guided approach in which ctDNA is evaluated at 2 time points post-surgery. And if the patient is positive at any of the time points, they receive adjuvant chemotherapy, so treatment, sort of the standard adjuvant treatment. But if they remain negative for both of those time points, then they were de-escalated to observation. The primary endpoint here was recurrence-free survival at 2 years. Again, a non-inferiority study. And as you see here, this is the update of the study at ASCO last year, really showing that, of course, the primary endpoint was met, but that the recurrence-free survival with the ctDNA-guided approach remained non-inferior to standard adjuvant therapy with longer follow-up. So these results really represent a landmark study for the use of ctDNA to improve clinical outcomes. And in this case, the reduction in the use of chemotherapy without a survival detriment. So to summarize, blood-based ctDNA is a non-invasive and a highly specific tumor marker. It is routinely used right now in the clinic to identify actionable alterations such as EGFR and ALK, but primarily in the metastatic setting, and it's not yet ready for prime time for early stage disease. However, there are emerging ultrasensitive ctDNA assays that are increasingly accurate at predicting pathologic response and survival in early stage disease. So we really are poised to take the next step in bringing this to clinic with adaptive clinical trials that will demonstrate the clinical utility of ctDNA for MRD detection and disease monitoring for our early stage patients. Thanks.
Thank you, Dr. Lamb. That was excellent. I'm sure there's lots of questions on this, as this is, you know, really helping guide us where this is going to go in the future. And so we're going to hold on questions right now, and I save them for the end. So we will have time for discussion. But I want to introduce my friend and colleague, Dr. Matt Strickland. He is one of the lead oncologists at MGH, really focusing all his efforts in esophageal and gastric cancers. So I'm excited to hear his talk. So I will give him the stage.
Thank you so much, Dr. Schumacher, and thank you to everyone for listening and tuning in. And Dr. Lamb, what a great talk and opener for our webinar tonight. All right, so very pleased to talk about the data for circulating tumor DNA and how it informs our management of patients with esophageal cancer.
I don't mean to interrupt, Dr. Strickland. Will you go ahead and put it in slideshow, please?
Oh yeah, my apologies.
That's okay.
Let me troubleshoot for just a moment.
Should be.
Sorry about that. Stand by.
That's okay.
All right, how's it looking on your?
Perfect. Yep.
Perfect.
Thank you.
Great. Thank you.
Thanks, everyone. All right, these are my disclosures. And so I wanted to start by framing our clinical problem. So for those of us, particularly in a multidisciplinary group that treat patients with gastroesophageal cancer, we really have a brutal enemy that we encounter daily in the clinic. Data from 10-year follow-up from the CROSS trial still leaves patients with a 10-year overall survival at less than 50%. And then recent data from this landmark report from the EZAPEC trial that was presented at ASCO this summer, which compared perioperative FLOT to the CROSS paradigm, still leaves patients, in this case at 5 years, with an overall survival of about 50-50. This is a very difficult discussion to have and knowledge to have as a patient embarks on a so-called curative paradigm. So we desperately need to deploy better and all tools available to attempt to move the needle for our patients. One component to the clinical problem for gastroesophageal cancers is considerable molecular heterogeneity. We can see here from this translational effort published in Cancer Discovery that basically looked for concordance versus discordance of genomic alterations across primary and distant mets in gastroesophageal cancers, that a low fraction of genomic alterations are actually shared. And then that fraction is even lower when it comes to actionable gene amplifications. So molecular heterogeneity is a big component to the overall clinical problem. And again, underscoring the need for new and improved tools. And that does, lead into the putative potential for liquid biopsy and circulating tumor DNA. As Dr. Lamb introduced, and I think the group is well aware, a blood sample will essentially undergo extraction of cell-free DNA. A subfraction constitutes the circulating tumor DNA, which can not only be quantified, but profiled as well for genomic landscape, epigenomic landscape, and others. And then this leads to downstream clinical applications that we're basically going to explore throughout the talk. A quick note in terms of the timeline of development. I was actually surprised that circulating tumor cells were discovered in 1869. I couldn't believe it. But a little bit more pertinent to our talk, ctDNA was first identified in 1948. That also kind of blew my mind. I wasn't expecting that long ago to have appreciated circulating tumor DNA. Really importantly, we began first picking out oncogenic drivers in the mid-1990s. And then ctDNA started going into clinical practice, or you could say clinical mainstream, about 10 years ago. Couldn't help myself. I needed to look at that first report of circulating tumor cells from 1869. And sure enough, this is what it looks like. This highlighted section reads, "A case of cancer in which cells similar to those in tumors were seen in the blood after death." And this was described by Dr. Ashworth. Pretty interesting. Moving on, Dr. Lamb did cover this, but it is a fundamental consideration when considering different ctDNA assays and how you're using them for your patients. Tumor-informed testing, of course, is a custom panel. It can be a little bit higher cost and increased time to develop a custom panel, a custom signature. But then subsequent tests actually are cheaper and do have a rapid turnaround time on the order of 7 to 10 days. Now, on the other hand, tumor-naive testing is timely, does not require additional tissue, and most platforms have proprietary genomic, epigenomic, and other signatures that act as surrogates for underlying genomic landscape. And they basically call with reasonable confidence those genomic alterations, and of course, report it to the treating provider. So ctDNA does capture molecular heterogeneity. It's well positioned to do that. And jumping back to that study that I had introduced, when these authors included cell-free DNA and ctDNA analysis, in a third of patients, ctDNA was positioned to capture an actionable genomic alteration that allowed a treatment change for that patient's trajectory. And so that's a tiny example of the power for ctDNA to guide clinical management. Also wanted to explore a single patient scenario, again, in the theme of molecular heterogeneity. So this patient's primary tumor is HER2 positive. The lymph node metastasis is HER2 negative. Conversely, the same primary tumor is positive for FGFR2, or I'm sorry, negative, but then positive in the lymph node. And so looking at the ctDNA analysis and copy number here, we can see that there's significantly higher expression of FGFR2 copies compared to HER2, which is down here. And so this patient presumably pursued an FGFR2 directed therapy, or at least the point is ctDNA can empower us to make these kinds of decisions at this kind of resolution. And so ctDNA has applications across the curative and resectable setting, as well as the metastatic setting. But because of our multidisciplinary audience, I did choose to focus most of my talk in the locally advanced setting and curative paradigm. This is a summary slide that I've created, and I often share it with fellows and trainees. What I'm trying to get at is a global sense of what is informing the modern approach to gastroesophageal cancers. You can see here across our, loosely defined 3 anatomic sites, we have several options in the neoadjuvant setting. The CROSS trial had a paradigm dominance for a long time, since 2012. In terms of stomach cancer proper, around 2019, perioperative FLOT came to the forefront in terms of optimal regimen. And then GEJ tumors and patients that have GEJ tumors have been included across the board, and that leads to more options for that anatomic location. But again, I want to highlight very recently a perioperative FLOT strategy in patients with esophageal and GEJ tumors did perform better in terms of DFS, OS, compared to a cross paradigm. And this was without sacrificing R0 resection rate, surgical morbidity, or the proportion of patients that make it to surgery. And so that's a salient update in treatment paradigm. Now, 3-drug chemotherapy, i.e. FLAUD, is quite difficult. So the cross paradigm is not going away. However, if a patient is a FLAUD candidate, then perioperative FLAUD is probably better. If they are not a FLAUD candidate, then we would be thinking about chemoradiotherapy. I also want to highlight that there's a stronghold in the adjuvant setting for patients after chemoradiotherapy for adjuvant immunotherapy, almost doubling the DFS. But if we simplify this treatment paradigm and think about when we might collect ctDNA, it might look something like this. So these time points on the bottom are quite intuitive. I want to point out that serial testing does increase the performance, sensitivity, and specificity of the tests. But it's equally important to get, if possible, on treatment time points, because we know ctDNA kinetics also are predictive of downstream outcome and how a patient will do. So this is a meta-analysis published in 2022 involving 15 studies to date for patients with esophageal cancer. And what I want to point out here in terms of diagnostic performance and surveillance, or performance in the surveillance setting, the sensitivity is on the order of 0.71 and 0.49. The specificity, on the other hand, is quite high, 0.99 and 0.96. And I would say, not unlike the data that Dr. Lam covered, that sensitivity tends to be moderate at best, but specificity tends to be quite high. There are some ways to improve sensitivity and specificity. One could draw more blood. The assay might broaden the molecular signature to combine multiple planes, that's to say genomics, epigenomics, or others, increase the number of serial collections, or actually combine tumor agnostic and tumor informed methodologies. It doesn't have to be one or the other. But is ctDNA prognostic in patients with esophageal cancer? This is one of the largest cohorts to date. It's a real-world cohort. It was studied by Dr. Huffman at DFCI and my mentor, Sam Klempner. It's about 300, almost 300 patients here, almost 1,000 samples. And they subcategorize patients into interesting cohorts based on time of collection. So preoperative setting, MRD, which is essentially defined in this study as 16 weeks after, within 16 weeks after their surgery, patients who had ctDNA positivity at any time, and then patients that were on surveillance proper. And we can see here, first looking at patients that ctDNA positive test at any time, there's a striking separation of curves. We're looking at relapse-free survival. On the left, we're looking at an aggregate of gastroesophageal cancer patients, and on the right is patients with esophageal tumors. Now, the numbers are still somewhat low, but you can't deny this striking separation and hazard ratio of 55.6 in this case. So ctDNA positivity portends a very bad outcome. You can see here, when compared to clinical pathologic variables, ctDNA positivity far outperforms those clinical pathologic variables in terms of risk factors. This is looking at the time point within 16 weeks of surgery. We can still see this strong prognostic performance. And then finally, ctDNA assay in the surveillance period maintains this strong performance and prognostic ability. A separate cohort that is also one of the most notable to date in the gastroesophageal space is a retrospective cohort. Lizzie Smith is the senior author on this study. And these patients all had resectable gastroesophageal cancer, just shy of 100 patients. But one of the advantages to this study was the deep clinical annotation. This was mostly a T3N+ patient population. And I include this zoomed out view of the swimmer's plot only to underscore what I just said, that they really had deep clinical annotation of these patients. The first point I wanted to make is that in the locally advanced setting, there is actually reasonable ability of ctDNA to yield robust molecular profiling. We can see that that's true for both the pre-surgery time point as well as the recurrent time point. And these drivers in these particular data shown are well known in the gastroesophageal space. And so, you know, the ctDNA is performing robustly here. This also opens up the avenue to design biologically directed neoadjuvant clinical trials. And ctDNA could really be part of that and inform the pathways for each treatment arm. Just a thought. Also wanted to quickly review the role of clonal hematopoiesis of indeterminate significance. So CHIP actually in this study was detected in 23% of patients. These are some clones with somatic alterations that are essentially non-cancerous. And the more trips around the sun that we all take, the more CHIP can actually be detected. And it can be robustly detected in peripheral blood, plasma, and therefore ctDNA assays. And so these next data that I wanted to show highlights that when CHIP variants are included, you still can see this prognostic strength of ctDNA status. But when CHIP variants are excluded, the performance actually increases several fold, here with the hazard ratio of 5.55. So an important consideration, depending on selection of which assay, whether CHIP variants are being filtered. This is also true, on the last slide I showed overall survival, this is also true for DFS here. And then this is the largest study to date. This is just over 1,600 patients. This study was done by Steve Marin from MSK. We can see here that, again, strong prognostic ability. And I wanted to provide examples of what the clinician might look at when they're receiving the ctDNA report. On the left, we have ctDNA that basically converted from positive to negative. Now, it was still positive right after surgery, but eventually cleared with presumably adjuvant therapy. Now, on the other hand, this patient had a preliminary ctDNA positive status, and that positive status persisted. Unsurprisingly, the patient on the left was recurrence-free at 24 months, and the patient on the right did have a short interval recurrence for their patient trajectory. So, exactly as Dr. Lam pointed out, prognostic ability is important, and you know, it seems very positive, but what does this actually mean for us as treating providers? In the gastroesophageal space, we also need trials. Right now, there's a paucity of prospective and certainly randomized data. I did want to review a very clever clinical trial design from my friend and colleague, Dr. Aparna Parikh. She's a colorectal cancer expert, and I did want to take the audience through this. Patients with stage 3 colorectal cancer received standard adjuvant therapy. They were then risk stratified by ctDNA status. If negative, per standard of care, they went on to surveillance. However, if positive, they then went on to receive biologically directed therapy. If MSI high, immunotherapy. If BRAF mutant, anti-BRAF directed therapy. Same thing for HER2 positive, anti-HER2 strategy. And then if patients did not have an actionable genomic alteration, they did go on to receive more, but different chemotherapy. This trial is ongoing. We're eager to hear the readout, but it is a very clever example of how we need to be designing similar trials in the gastroesophageal space. I did want to, it's a bit of a provocative question, but could DNA guide non-operative management of patients with esophageal cancer? As the group can imagine, this would involve some kind of neoadjuvant therapy, risk stratification, and then, you know, presumably after a complete clinical response on endoscopy, a tight surveillance schedule. I think because our outcomes are still so poor, we're a long ways away from this. However, if there was a patient population to potentially begin with, I think that it might be patients with MSI high tumors. I say this because we know from phase 2 trials thus far that treating with neoadjuvant immunotherapy does markedly improve the pathologic complete response rate. This might be a patient population that these trials could start with. Similarly, we know that esophageal squamous cell carcinoma tends to be quite sensitive to chemo or radiotherapy. That might be another patient population to start with. That being said, there are not ongoing trials yet. And then I wanted to touch on ctDNA and its role in definitive chemoradiotherapy for patients that may not be a surgical candidate. This study, this was a translational study from a design that involved definitive chemoradiotherapy combined with PD-1 blockade. And really simply, there were 3 collection time points: pre-therapy, on therapy, and then post-therapy. And the primary endpoint of the study was complete clinical response. We can see that those patients with ctDNA negative status had a greater proportion of actually achieving complete clinical response. And that was true at each of these 3 time points. And so in some ways that's intuitive, but it's nice to see that the ctDNA readout is performing reliably. Similarly, it allows the authors to stratify by the pattern. So these are patients that were negative and they remain negative across 3 time points. Pattern 2 and pattern 3, these patients started out positive, but then they converted to negative. For these patients, it was a quicker time point in the middle of therapy. And for these patients, it took until the end of chemoradiotherapy. And then finally, patients that started out positive and failed to clear and remain positive, as you might imagine, when grouped as such, those patients did the worst, and the patients that remained negative did the best. And so again, seems to be performing reliably in a definitive chemoradiotherapy context. Very interesting. But there was one caveat to this study, which was, how did ctDNA compare to the PET-CT that all patients get after chemoradiotherapy? And so we can see here the sensitivity and specificity of the PET-CT, and then comparing to ctDNA after having completed therapy. The sensitivity is marginally improved, but the specificity is significantly lower. And so when you look at the PFS and OS of PET positive recurrent patients and ctDNA positive patients, they're largely superimposed. And so this is a big problem. This suggests that ctDNA in this study is not adding much beyond what we already can gather from the PET-CT readout. I think that is a challenge. That being said, this is only one study and should not derail the future development of integrating ctDNA to this paradigm. A few examples of how ctDNA from the metastatic setting is useful. Generally speaking, the amount of ctDNA detected is proportionate to the metastatic burden. And then there is some site specificity with respect to level of ctDNA that can be detected. It's actually quite hard for patients with peritoneal disease to detect that site-specific DNA. In other words, we think that disease in the peritoneum sheds less compared to the liver or the lung. And then this is just very briefly to say that ctDNA kinetics are powerfully prognostic in the metastatic setting. Here, the definition was a decrease by greater than 50%. Patients basically did better, whereas less than 50% is a surrogate for possibly intrinsic resistance. Molecular profiling is robust and is much better and easier in the advanced setting. And then the last note is that ctDNA does capture a significant fraction of genomic alterations that are not shared by either the primary or not captured by tissue-based testing of either the primary or a distant metastasis. And so there's considerable clinical utility in that respect. So takeaways from the data thus far is that ctDNA is strongly prognostic for how patients do in the gastroesophageal space. There's moderate sensitivity, high specificity. Unfortunately, we currently lack randomized prospective data. That's a gap that needs to be addressed. That being said, ctDNA is an emerging, putatively powerful biomarker, and that is across all time points of the patient journey, whether it's resectable or unresectable disease. And some future directions, I think, are non-operative management, as we discussed. Those will have to be very thoughtful trial designs. How can ctDNA inform adaptive neoadjuvant or adjuvant therapy? And a quick note, jumping back to the results of the EZAPEC trial, in some ways, radiation has moved out of the forefront of neoadjuvant therapy, but we're left with this still powerful tool. And I wonder if ctDNA can be the future pathway to know when and how to integrate radiation into perioperative management and for whom. I wonder if ctDNA taken seriously serially might shorten the conventional surveillance period. And then we already know we can detect ctDNA in other non-blood sources like urine, saliva, CSF, and more. And so I think that we will see more studies from those tissues. One trial to watch is a patient population with locally advanced gastric and GEJ cancer. They will receive FLOT in the neoadjuvant setting, go on to surgery, then be risk stratified by ctDNA. If the tumor is HER2 positive, these patients, instead of getting standard of care postoperative FLOT, will get trastuzumab deruxtecan. This is an example of ctDNA adapted treatment that I find exciting, and so this is definitely one trial to watch. This is my reference slide, and I want to thank everyone for their attention, and these are my mentors right here.
Thank you, Dr. Strickland. That was just such a thorough talk, and really thought-provoking, which is exciting for us to be able to maybe change paradigm in the future. I think what's challenging right now, and this is why Dr. Specie and I really wanted to inform our colleagues and have you guys speak to them, is that you feel like there's so many kind of commercially available tests and what's good and what's right and how do we use them, and when is this going to be streamlined? And you brought up advancing clinical trials or creating them, and I think that that's so important. So what are your thoughts on all these different assays and which ones to choose? And that's one question I have. And the second is, I know it was briefly mentioned and both of you can answer, do you think this will ever be utilized for screening?
So I can go first. I think that it's definitely a free market, and that is a challenge. There's multiple platforms, and even within one company, the platform is constantly evolving. And I can already see changes to some of the reports from the tests that I routinely get. I think it's a challenge. I don't think there's an easy way around that. Part of that challenge is, as a sole provider, you're probably going to stick with, a few set of platforms, right, for consistency. But then the colleague next to you might have slightly different practice. I think that the best we can all do is continue to go over the data thoughtfully and respond in kind. But I think there's not an easy answer to overcome that challenge.
Yeah, I definitely agree with that. I mean, I think in the clinic today, in some ways, it's actually quite simple, at least in the lung cancer space. There really is no, for our early stage patients, there really is no ctDNA test to send right now that has robust randomized phase 3 data that shows that it improves clinical outcomes. So it's really quite a great question, right? Because we actually have access to multiple tests like Signatera and Personalis, I mentioned, is an emerging one. Guardant Reveal is another. There's a whole host of these. But the key thing to keep in mind is that none of these have prospective data yet that demonstrates that they improve outcomes. So, I think it's been pretty well shown all the way back to when Dr. Sapesi and I were working on this, with even the earlier generation ctDNA assays. I think it's been shown across all tumor types, really, that ctDNA is really a very specific and accurate biomarker for tumor burden. But now we really need to take that next step to have those prospective trials to truly demonstrate that just because we can tell you that the disease has a high chance of coming back, that we can do something about it that will actually change the trajectory of your cancer journey.
Right. I'm going to answer a question from the chat from Dr. Sharon Benar. Do you feel that all lung cancer patients with ctDNA should be treated with neoadjuvant treatment regardless of pre-op imaging?
Yeah, that's a tricky question because there's a lot of sort of nuances, right? Because in some ways, you really have to know what the operating characteristics of the test are. If it's a really highly sensitive ctDNA assay that, for instance, in the diagram that I put up, if it's able to really detect a T1b tumor, then potentially that patient does not need neoadjuvant therapy as per our current standard of care. And it would be consistent with our clinical management based on the CT scan. But if you actually have a ctDNA assay that is less sensitive, but is able to pick up ctDNA in that same patient, I mean, in a early stage patient, then potentially that would suggest that there's actually quite a bit of tumor for that sort of more rudimentary assay to be picking up ctDNA. So so it really depends on what level of ctDNA is being picked up, and for that you have to know what your test is capable of doing.
So actually, Vince and Dr. Sling, can I sort of follow up on that? Because so ctDNA, just so I understand, obviously, these are fragments of DNA. Can we truly say that there are actually circulating metastatic cells within the bloodstream? And then based on that sort of a seed and soil theory, are we saying that, or can we say whether there's, let's say, oligometastatic disease, or there's a cluster cell somewhere within an organ that are shedding into the bloodstream, versus are there actual metastatic cells circulating in the bloodstream trying to, cross, basement membranes, and are they still looking for sort of a fertile soil of where they would, where they would stay? I mean, can ctDNA sort of differentiate that? Because then I have a couple other questions about treatment. I mean, would it still be fair then to use some local therapy, like you said? I mean, if you have stage 1B tumor, we know that in primary tumors that shed DNA, if we resect them and we clear the DNA, those patients also do reasonably well. It's the lack of clearance that suggests there's disease hiding somewhere else. So we don't really know whether, just because you're shedding DNA inside the bloodstream, then we don't know whether you should give local therapy versus systemic therapy. Am I correct about that?
Dr. Strickland, you want to take that first?
Yeah, I think these are fascinating, questions about etiology. What I can tell you is that, the data, the recurrence patterns in the gastroesophageal space suggest that micrometastatic disease is the problem and is the driver. And that is to say that distant relapse is the dominant fraction of that pattern. So nobody can know for sure, but I do worry in the setting of ctDNA positivity that it's micrometastatic disease that's going to, get us, so to speak. It's just a thought, but we would have to come up with very interesting, maybe even preclinical studies to try to tie together a more robust mechanistic link.
Yeah, no, I mean, I agree that if I can just sort of follow up on that, then so what about, for both of you as medical oncologists, what about then treating patients based on ctDNA in asymptomatic patients, or do you wait, or is it better than to wait and treat them, when they become symptomatic? And, what about treatment toxicity, sort of, and other things, and switching treatment paradigms? How do you, today, when it's not necessarily completely standard of care, more on trials, how do you utilize these data?
Yeah, that really hits at the crux of the issue, really, right now in the clinic, and it goes back to what Dr. Schumacher actually asked initially. We actually have patients in the metastatic setting, for instance, that are, requesting that we order ctDNA to monitor their disease. And because they want to see if the kinetics change, because we have data, especially in the metastatic setting, to show that if your ctDNA levels go up, there's something wrong in terms, they're really strongly suggestive of progression or recurrence. And then even in our early stage patients, they get one of these tests that are, hanging around the clinic after their surgery, and then they get blood draws every few months or whatever. And so we're dealing with that now. And so it goes back to what Dr. Strickland and I have really sort of tried to emphasize tonight, which is, what do we do with that data? And that's the conversation we have with our patients, So yes, that ctDNA level is now positive after your surgery. That's quite worrisome. And, going back to your question, Boris, about, what does it actually mean to be positive? I would say we actually have tons of data now in clinical cohorts that really suggests that ctDNA is very specific and has unique qualities because of its fragment size and methylation patterns and such that the tests that we have now, the majority, the high quality tests, really do signify a high chance of either progression or micrometastatic disease.
So do you treat based on it?
Yeah, so that's the question, because I think you should, but we need to run the trials to actually demonstrate
Yeah.
that. Because
Hurry.
yeah, there are toxicities and
Yeah.
financial considerations and such, but yeah.
And
We
also to
also-
Dr. Strickland's point, like, I wonder too, if we're following this longitudinally, if you were in the neoadjuvant setting and you're getting a patient ready for surgery and that hasn't dropped at all, that's a bad prognostic sign. We're still kind of stuck with this a bit, but is that a red flag where maybe you try a different therapy before surgery, to change? Would that ever be something that you would utilize? Because the worst is when we take a patient to surgery and there's micrometastatic disease undetected, and you see that come back in a very short time after surgery. I mean, that's kind of the worst feeling a surgeon has.
Yeah, I think that if, particularly if a patient is borderline, right? If that, for esophageal cancer, if maybe the local regional lymph node pattern is stretching what the radiation field will be, and that ctDNA level is not coming down, I could conceivably see a scenario where we might say, okay, hold on here. Patient happens to have a high PDL1. Maybe we're going to treat this as an unresectable, locally advanced case, and then induce with, hopefully, biologically directed therapy, and then possibly come back to either consolidative chemo RT or just surgery at that point.
Yeah, I think there's so much to learn in this space, and we thank you. I think we're almost at time. We might have time for one more question. Anyone have another question? I got a yes from the wrap it up. I think that there's, so much to learn from this space, and to both, Dr. Strickland, your point, Dr. Lamb, your point, we need to be involved in the trials, all of us. And, happy to support that. Even from kind of looking at this through the STS lenses, this needs to be done. It's very important, and it will help, I think, really create some landmark studies. So thank you very much.
I just can make one last comment. I still think that, obviously, as we keep chasing cancer, that I still believe local regional therapy will be important, because, again, it can inform through the final pathological specimen, potentially, again, and through ctDNA, maybe at some different and switching therapy to, to different adjuvants, etc. So I think we we're here to help each other with systemic and local treatment as well. So, but thank you both. This was really quite outstanding, and thank you, Dr. Schumacher. You can
Yes,
close
great discussions. Thank you.
Thank you so much to our moderators and our panelists tonight for your participation and insight. Thank you to our sponsor, AstraZeneca. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, opportunities to help you grow professionally. Learn more at sts.org/membership. Registration is now open for STS 2025. So please find more information on our calendar of events at sts.org. We're going to put the link to the registration page in the chat. But thank you so much to everybody again, and we wish you a great night.